Well, hello and welcome to our CEU session. My name is Jane Houston and I'm the Clinical Director of Midwifery and Women's Health at Frontier Nursing University. And I'm really delighted to introduce my friend and colleague, Dr. Oliver Grundmann, for tonight's presentation. Oliver Grundmann, PhD, received a bachelor's degree in pharmacy and European pharmacist license from the University of Munster in Germany in 2004, before beginning his graduate studies at the University of Florida. While continuing with his PhD in pharmaceutical sciences, he worked for the forensic science program after graduating with a master's degree in forensic toxicology with a minor in statistics. His research interests include the search for new treatment options from natural products for central nervous system and gastrointestinal diseases such as anxiety and depressive disorders, as well as irritable bowel syndrome and cancers of the gastrointestinal tract. He also is interested in the implementation and impact of national and international collaborations for curricular development in the health sciences with an emphasis on distance and online education. Dr. Grundmann serves as the Director and Faculty Advisor for the online Master of Science and Graduate Certificate programs in Pharmaceutical Chemistry and Clinical Toxicology at the College of Pharmacy at the University of Florida. It gives me a great pleasure and honour to introduce Dr. Oliver Grundmann. Thank you, Oliver.
Thank you, Jane, and it's a great pleasure to present at Frontier Nursing University. This is the first time I'm doing this, and I apologize for the bad background. I actually was hoping that I would be back from a trip abroad, but unfortunately, I was delayed on my travels back, so I have to give this presentation on my hotel room, from my hotel room. So I apologize for that. Today's presentation stems from an acute opioid epidemic that is spreading throughout the United States. And it is impacting not only directly people that are affected in the community, but especially the vulnerable. And that is also affecting pregnancy and nursing care. And that will be a topic that I will be discussing in today's CEU session for those who are in attendance. The learning objectives for this CEU session will be that at the end of this presentation, you should be able to interpret the symptoms of the opioid toxidrome. So this is more of a little bit of a review session, what most of you from your clinical practice point will likely have experienced, unfortunately, many times, and take appropriate steps to stabilize a patient that has and is showing the signs of the opioid toxidrome. Relate the symptoms of neonatal withdrawal and abstinence syndrome to the effects of the mechanism of opioids. So I will briefly discuss the pharmacology of opioids. Develop a treatment approach based on the neonatal abstinence syndrome, or in conjunction with the healthcare team. And this is often an interdisciplinary team that will work not only with the neonate and with the newborn, but also with the mother and with the social network. And then contrast current and future approaches to the prevention of the neonatal abstinence syndrome and opioid use during pregnancy. And there's still a lot of work that needs to be done to optimize this process and this whole treatment approach that we currently have and hopefully seek in the future. So a few very brief notes first. I do not have any conflicts of interest. There are no commercial interests to declare, and I also don't have any current or former research grants or fellowships sponsored by companies or stakeholders associated with opioid drugs. I am involved a little bit in an herbal supplement called Kratom that some of you may have heard about, that is currently in the news, which is not seen as an opioid drug, but that contains compounds that are acting on the opioid receptors. and that is currently being viewed by the FDA and the DEA and is being evaluated for potential classification as an opioid drug. And as Dr. Houston already mentioned, these are my major research interests here, mainly natural products with CNS activity, also drug interactions with supplements, which is an increasing interest not only for pharmacists but for healthcare team members in general, and recently the chemistry and pharmacology of kratom. But I'm involved with a number of different agencies that are dealing with opioid drugs and with drugs of abuse in general through my work as an academician. So when we look at the opioid epidemic in general, and this is the latest statistics published from Health and Human Services in 2015, overall, we are really seeing a crisis that has been approaching from a long time coming. In 2015, 12.5 million people have been misusing prescription opioids. Misusing doesn't necessarily mean that they have been abusing it, but it means that they have not been using it in a manner as it has been prescribed to them by their healthcare providers. And among these 12.5 million, 33,091 died from prescription opioid use. And that obviously is an unacceptably high number. We also see a rise in the death from heroin abuse, and that is obviously an abuse. There's not a misuse, but an abuse because it's an illicit drug. And the overall economic costs, not only the healthcare costs, but the economic costs associated with this rising misuse and abuse in opioids, not only prescription, but also illicit opioids, in 2015 was $78.5 billion in the US alone. And if we look around the US, you see certain centers there you really see a higher number of overdose deaths in 2015, and from light yellow to dark red, you see where really the centers are, and it's mainly centered here in the Northeast, down into Arkansas, around this area, and then we see centers in New Mexico, Arizona, Nevada, and in California. So these really seem to be the centers that we currently have in the United States. And along with that, with the deaths, come also the misuse and abuse, higher numbers usually that accompany those opioid epidemics. So how did it start? It was really an issue if we go back to 2000 here, in the year 2000, that's where this graph starts, where we saw an increase and a rise in the misuse and abuse of prescription opioids. And that led to an increase in substance use disorders. And based on that, more and more people also then started to increase their use in heroin and illicit drug use. And especially with the introduction of cheaper and more purer heroin, that in 2010 started to flood the market. And you clearly see in 2010 how here, around that time, you see how heroin and fentanyl laced heroin really started to exponentially increase the overdose deaths. That really marked a change in the deaths that occurred from that point onwards in 2010. What is so important is that fentanyl is about 80 times the potency of morphine. So we're really looking at a highly potent drug that was initially only developed and used to initiate surgery, anesthesia for really severe pain as a patch product for basically skin patches. And it can be produced relatively cheaply, and obviously because it is usually used in very low amounts, it was flooding the market, and overdosing is very easy. And therefore, it can be obtained in relatively low amounts. And really from 2010 online, you see how we really exponentially increase in our overdose deaths. Unfortunately, many people have since then switched to heroin. You don't see an increase in prescription opioid abuse and the associated deaths, but you really see a spike in heroin and fentanyl overdose deaths. When we look at the opioid toxidrome, the symptoms that somebody experiences are probably familiar, so this is just a brief review. Overall, the opioid toxidrome is a depressed CNS system. So we will see depressed consciousness, decreased reflexes, and most importantly, depressed respiration. So if breathing rate is usually around 12 to 20 rates per minute, breaths per minute, then it will definitely be below 12, usually around 4 or even below that. If respiratory failure sets in, that's when we reach the point where we might have to intubate and directly assist the patient externally with respiration. In addition to that, we have decreased heart rate and blood pressure. Classically, the patient will present with pinpoint pupils and decreased or absent bowel sounds. Also, in terms of diaphoresis, they will be dry. They will present with decreased core temperature, and potential needle tracks or marks on arms or thighs might be observed because in those who are abusing heroin or fentanyl even, you will classically see that. And symptomatic treatment obviously includes mostly supportive. Respiration is really the classical one. Heart rate and blood pressure is then followed. The treatment approach is obviously the pronounced respiratory depression or failure. Intubation is then usually indicated, and naloxone is now really the treatment of choice. Naloxone intranasally in 0.1 to 0.4 milligrams IV in repeated doses can be trialed. 4 milligram intranasally is a new formulation that can be trialed even by untrained personnel. Otherwise, IV is suggested until you see an increase in the respiration rate. Don't try to completely raise the person from a less conscious to an entirely conscious state. This is only intended to get the respiration rate up into a state where they reach 12 breaths per minute or alike. Don't try to get them up to a fully conscious state. The issue is that with constant heroin or opioid abusers, you might get them into a withdrawal state, and then you might see seizures, very unstable cardiovascular system, and then you might see a very uncooperative patient, very unstable cardiovascular system. Later on, though, because naloxone has a shorter half-life and doesn't stick around as long as an antagonist at opioid receptors to antagonize the opioids, you might have to re-administer naloxone, so you have to watch the patient closely. It is important to potentially re-administer naloxone or then use a drip of naloxone. After the respiration rate has been stabilized, blood pressure should be stabilized with saline, and then continuously monitor the patient, treat according to the symptoms. For pediatric patients, it is important to also look at the respiratory rate. Usually, this requires then to administer 0.1 milligrams per kilogram naloxone if under 20 kilograms or under 5 years, until the respiration rate is above 15. And if we look at somebody who is a pediatric patient who is above 20 kilograms or above 5 years, we look at 0.1 to 2 milligrams until the respiration rate is above 15. Children sometimes may present with more variable overall vital symptoms. They might present with much more depressed mental status, even at relatively low opioid doses. So it is important to monitor them closer in comparison to an adult. That is important in children. Their metabolism is not fully, the hepatic metabolism is not fully working, it's not fully developed. The CYP enzymes are not fully developed. So it is important to be aware of that. In some cases, naloxone may be metabolized faster. Often their kidney functions are rapidly overturning and eliminating naloxone. So administration might have to occur at a faster rate. So monitoring is very important. The cumulative dose of naloxone is usually up to 10 milligrams for an exposure case. But in the case of fentanyl or its analogs, it might require much higher doses of naloxone over a longer period of time, because it is so much more potent than morphine or heroin or the usual opioids, that it requires much higher doses. The usual kit of naloxone, of the antidote, contains 3 doses of naloxone, and that is usually exhausted if somebody has overdosed on heroin that has been laced with fentanyl or fentanyl itself. So there it is very important to get the patient either intubated and externally respirated, or to have directly IV naloxone excess on hand. That is very important, no matter if it's a pediatric patient or an adult patient. Just very briefly on the pharmacology of opioids, we have 2 separate terms that are sometimes a little bit mishandled, and I don't want to get into too much detail about here. Opiates are in the strictest term the naturally occurring ones, the morphine, codeine one, that are naturally occurring in the poppy seeds. And opioids are both the natural and the synthetic ones. So the opioid receptors are those on which both the natural and the synthetic ones are binding to. They are located both in the CNS and in the peripheral nervous system. PNS here stands for peripheral nervous system. And there are 3 different receptors, the mu, delta, and the kappa receptors, and each of them have a slightly different function. They all contribute to the analgesia, which is what the opioids are commonly prescribed for. The mu receptors are also responsible for, in part at least, for the respiratory depression. They are in the central nervous system. Peripherally located opioid receptors are responsible for the constipation that is associated both in therapeutic and in supratherapeutic doses. So in overdoses, patients will often present with constipation. And that is related to all of the opioid receptors. that are located in the peripheral nervous system. Basically, what they cause is, in its natural state, when they are not occupied, on the left side here in this little gimmick, in this little diagram, you see that if they are unoccupied, that the neuron actually releases GABA and binds to the GABA receptor on a neighboring neuron, and that prevents the release of dopamine from this neuron. And so, therefore, not as much dopamine binds to the dopamine receptor, the postsynaptic dopamine receptors. If something like morphine or heroin bind to this receptor, then GABA release is actually reduced. GABA is an inhibitory neurotransmitter. So if GABA release is reduced in this case, that then indicates that actually the release from the neighboring neuron, the dopamine release, is not inhibited. So that means that more dopamine is actually released, and that then allows dopamine to bind to its postsynaptic receptor. And that serves two functions. It serves, one, the function that dopamine can exert its effects postsynaptically, its normal physiological effects, but also dopamine is our neurotransmitter, our reward neurotransmitter. So it has the powerful effect that people seek as a reward, and that then reinforces taking the opioid again to get that kind of boost, this positive reward that we seek from eating chocolate or something else, as you know. So this was just a little bit of a review of opioid pharmacology. So a little bit of statistics on opioid use during pregnancy. The prevalence currently, as of 2013, so 4 years back, it's likely increasing since then, is roughly 6.0 cases per 1,000 hospital births of opioid use during pregnancy in 2013. That unfortunately is already an increasing trend, so we are definitely on the upwards trend. In 2008, an estimated 7,000 opiate exposed births occurred annually. This indicates that we are seeing an increase in the number of children that are potentially presenting with a neonatal abstinence syndrome, NAS. And therefore, it is likely that it is more common that you, as a healthcare provider, as a nurse practitioner, as a nurse, will see such cases in your NICU or as an OBGYN practitioner. There is a 6-fold increased risk of obstetrical complications if opioid use remains uncontrolled during pregnancy. Opiate withdrawal during pregnancy is usually not recommended due to worse outcome. So if a patient goes into a pregnancy and is using opioids, no matter if it is a therapeutic use, a misuse, or an abuse, one should not recommend that they withdraw from their opioid use during the pregnancy. There are protocols in place to keep them under a controlled opioid use during the pregnancy. It is therefore recommended that all pregnant women should be screened as soon as a pregnancy is confirmed, independent of prescribed or non-prescribed status, no matter if they have been prescribed opioids or not prescribed opioids. And then this follows a very simple abbreviation, SBIRT, and that is an evidence-based approach. And on every slide, you will find these little indicators here at the bottom where the sources are coming from. After opioid use has been confirmed, the screening, urine screen, and confirmation of prescription or illegal opioid use, A brief intervention is then suggested. This includes a discussion of risky substance use behavior that could affect both the mother and the baby. There are risks associated during the pregnancy in regards to stillbirths, low birth rate, as well as for high blood pressure and the like that affect the mother and the baby, and then a referral to treatment therapy to stabilize the patient on methadone, buprenorphine, or prevent withdrawal. And those mothers who are on prescription opioids will likely be maintained on opioids or switch to methadone, buprenorphine while they are pregnant, because that is usually what we have currently the best evidence and the most experience with. When we look at the prevalence of neonatal abstinence syndrome, which is the most likely presentation of a newborn that is born to a mother that has been using opioids during pregnancy, the clinical symptoms are CNS excitability, vasomotor signs, and gastrointestinal signs. So it is actually quite similar to what you would also see in terms of opioid toxidrome in a mother. It's a little bit more of a withdrawal symptom that you will see. And if you look at the states, again, you see a little bit of that here as well. We're looking at this area with a very high prevalence of NAS, and we then looking down here again in this area with a relatively higher prevalence again as well. For California, we don't have any data. I would assume at this point, though, that California would also present with a higher NAS prevalence as well. Meconium and urine screens may confirm diagnosis, but there is a relatively high false negative rate because of the turnover, relatively high turnover in urine of newborns. The differential diagnosis then can actually be made via hypoglycemia that is often observed, hypocalcemia, hypomagnesemia, hyperthyroidism, perinatal asphyxia, and intracranial hemorrhage. Obviously, when we get to that stage, intracranial hemorrhage should be avoided as good as possible. If we already know that the mother has been using opioids, then we want to monitor this newborn very closely. The NAS scoring system should be implemented as soon as possible. If we know that the mother has been using or during pregnancy has been using opioids, then it makes sense to implement the NAS scoring system that has been initially developed in 1975 and then has been refined again by Finnegan itself in 1992. And since 2009, we have been using a modified NAS scoring system. About half to 3/4 of newborns to mothers with opioid use will require treatment for NAS. So once a newborn is being monitored for NAS, for potential NAS, this is basically the scoring system that should be used. And when the requirements are being met, then it is very likely that the healthcare team will decide to implement treatment. What is very important is, as research has indicated for any newborn, is skin-to-skin contact with the mother for the newborn, and reduce sensory stimulations because of the CNS excitability. It's very important to keep the newborn relatively quiet. The NAS scoring should be taking place in the mother's room, and if within a 3 to 4 hour period the NAS score is equal to or above 9 on consecutive measures, then the newborn should be transferred to the NICU. And obviously what you see here, the biggest whammy is obviously a generalized seizure with a score of 8. That would be in any circumstance, no matter if it was an NAS scoring system or not, would be an indication, or would be cause to transfer a newborn to a NICU, most likely. The pharmacotherapy would likely start off with morphine sulfate if it's an inpatient newborn, and then likely if it's becoming an outpatient, then be switched to methadone or buprenorphine. The goal with all of this is to get the newborn transition it as quickly as possible off the opioid. The inpatient treatment basically always goes by this NAS scoring system. And I encourage everybody, I only looked at the NAS scoring system very briefly here, and you can look at how this is broken down, but I didn't want to spend too much time on it. But it's a fairly well-established system over the past 30 years, 40 years actually now. So if the NAS score is equal to above 9 for 2 consecutive measurements, then within the hospital stay in NICU, one should start off with morphine sulfate orally, and if the score, depending on how high the score is, above 24, you would give 0.20 milligram, and then on subsequent measurements evaluations, you would increase the dose depending on how high the score remains. When the score then drops below 9 for 48 hours, lower morphine dose by 0.02 milligram every 24 hours until it is discontinued. So this is, in the end goal. You want to discontinue, obviously, the morphine or any other opioid. Over time, the issue is if you up the dose, you obviously need to at some point reach a level where you want to stop increasing the dose, and this is a healthcare team decision. So this is very important to at some point make the decision to keep the newborn at a certain level and not increase it every 3 to 4 hours. So that is an important decision that should be made as a healthcare team, the nurses, you as the nurse, together with the attending pediatrician. If an inpatient is being transitioned to outpatient for newborns, it really depends on the severity of symptoms, ranging then really from 0.3 to 0.6 milligram every 12 hours. If the NAS score remains above 9, then it should be increased by 0.05 to 0.2 milligrams. And then the discharge only really happens if the score are below 9 for 24 to 48 hours on methadone maintenance. If it falls below 7, discontinue methadone and restart only if score is equal to above 7 as follows. And then you really have to lower the methadone relatively slowly, as you can see here in this chart. And usually this is done in conjunction with very tight interdisciplinary team, social services, usually in an outpatient treatment facility, the pediatrician will get involved, and so on and so forth. So This involves a lot of close follow-up with the respective mother and parents. So the discharge care of the mother and the newborn is quite important. Breastfeeding should actually be encouraged because it encourages the skin-to-skin contact and the closeness, the connection between mother and child, even if the mother is on methadone or buprenorphine. Contraindications are obviously hepatitis B and C, and the only exception here is maternal positive HIV status. Sorry, the maternal hepatitis B and C are actually not contraindications because it's not being transferred into the mother milk. And what's important here is the multidisciplinary health team, the addiction physician, obstetrician, nurse practitioner, social worker, and the public health nurse are important. The nurse practitioner, to hand it over to the public health nurse, is quite important to really get that close handover from inpatient to outpatient for both the mother and the newborn. Now, going back a little bit from what I mentioned before in the introduction, prevention of neonatal abstinence syndrome. What is important here is the identification and allocation of resources for mothers with a substance use disorder. This would require the reauthorization of the Child Abuse and Prevention Treatment Act of 2003. That requires primary care practitioners to report children born to mothers with substance use disorders to Child Protective Services. There was the Protecting Our Infants Act of 2015 that's providing research funding for neonatal abstinence syndrome and other measures to prevent and reduce opioid use by mothers during pregnancy. This needs to be renewed. And to my knowledge, I don't know if that has been done or is currently being done. There are two different models, the adversarial and the facilitative model in protecting mother and child health at the moment. And I think moving forward, we're looking more at the facilitative model in protecting mother and child health, keeping them together instead of trying to separate them. Where we try to identify ways to both help the mother and child as a unit instead of trying to separate mother and child and taking the child away from the mother. Obviously, that needs to be reevaluated over time. We need to be aware that what we need is we need to lift the mother out of that dependency, out of the substance use disorder, in order to get both of them into a better living condition over time. At present, we saw a rise in neonatal abstinence syndrome incidence from 1 in 1,000 to 7 in 1,000 hospital births just between the years 2000 and 2012. So obviously, the best strategy for a reduction in NAS is to reduce opioid use disorder in women. That is clear. And in contrast to men, the rate of opioid use disorders in women is still lower, but it still is too high, obviously, if we see this stark increase in NAS over such a brief period in time. Most of the opioid use disorders still begin with prescription opioid misuse due to prescription overprescription of opioids or diversion. How to address that is beyond this presentation, but it is important to be aware of that. And you as a healthcare practitioner can get involved if you see that maybe one of your patients is receiving 30 or 60 tablets of Percocet or hydrocodone or oxycodone or whatever prescribed if they only need 10 for a particular condition. So there are methods that we can try to reduce over-prescribing of opioids. So really the intervention should start in clinical practice here, in prescribing practice for opioid analgetics, reduce the amounts, monitor adherence, and also reduce doses. I think in some regard, our practice will reflect positively on patients in many regards. When we look at the future, currently methadone is really the treatment of choice for neonates and newborns when they are being discharged and becoming outpatient care, as well as for mothers during pregnancy. But buprenorphine may actually provide better treatment outcomes than morphine for inpatient and outpatient. The duration of treatment and the weaning was significantly shorter in one study compared to morphine of 63 infants, so 15 versus 28 days, so nearly cut in half. The median length of the hospital stay was significantly shorter for buprenorphine than for morphine. So this was just the hospital stay, not total weaning stay, the weaning duration, 21 versus 33 days. Adjunctive administration of phenobarbital to sedate newborns was similar in both groups. So sometimes other treatment options are necessary. Phenobarbital is obviously something that only is given if it is absolutely necessary to sedate a newborn. Unfortunately, there the buprenorphine group did not show any benefit over morphine. However, buprenorphine is not yet approved for treatment in newborns or in neonatal abstinence syndrome. It is approved for withdrawal and abstinence treatment in adults for opioid withdrawal, along methadone. So we might see it being approved in newborns as well in the near future. It has shown benefits because it's a partial agonist at opioid receptors, whereas methadone is a full agonist, and morphine as well. So it might show quite a few benefits. So to wrap it up, conclusions are the incidence of neonatal abstinence syndrome is increasing due to rising opioid use disorders, and that is primarily based on overprescription and potentially also a misdirected use sometimes of opioid prescription drugs. The opioid toxidrome is characterized by significant CNS depression. Respiratory failure is most common cause of death among the adult population. And these days, about 90 people per day in the US die of an opioid overdose. Naloxone is used to reverse immediate life-threatening respiratory depression. Opioid-dependent mothers are maintained on methadone or buprenorphine during pregnancy. As I mentioned, methadone is still the primary drug of choice because we have a lot more experience with it. The neonatal abstinence syndrome is often associated with longer hospital stays and slow weaning off from morphine or methadone. And as you have seen, this is associated with a significant burden both on the healthcare costs as well as on the healthcare team. And the scoring system is essential in making progress towards weaning the newborn off the opioid. Symptom severity needs to be evaluated frequently and dose adjusted accordingly, and that really requires very frequent monitoring, 3 to 4 hours basically. Whenever the feeding of a newborn is required, that's when you reevaluate basically. So it can be very taxing and tiring on the entire care team, as well as on the mother as well. So it is essential, though, to do it quite closely and pay attention to it, because the better this is tracked, the better that is documented, the better the newborn, the better the chances are that the newborn can be weaned off the opioid faster. The best approach to reducing neonatal abstinence syndrome is to prevent mothers from becoming opioid dependent. And that starts even before they become pregnant, by not letting them overuse or prescribe them too many opioids. And with that, I would like to thank everybody. Thank you for your attention and for giving me the opportunity to talk today. If there are any questions, I would be happy to answer them via email. My email address is down here, so feel free to reach out to me at any point in time. And I wish everybody a very happy holiday season and happy Christmas coming up as well. We already have December. Gosh, time is passing by so quickly. And with that, I'm handing it back to you, Dr. Houston.
Well, thank you so much, Dr. Grundmann, and we really wish you safe travels back to the United States and a wonderful holiday season to you and all your family. So thank you so much, and we look forward to hearing some great responses from the listening FNU folks and everyone around the globe that's going to be listening in to your presentation. So thank you again. It's great to see you.
Thank you very much.